to the Pharmacy Frontiers podcast. We're excited to come to you today with Dr. Tyler Woods, bringing value to independent pharmacy owners. Let me remind everyone that the Pharmacy Frontier podcast is available for streaming on your favorite podcast streaming app, whether it be Apple, Podbean, Spotify, or YouTube. Pharmacy Frontiers podcast is dedicated to the pharmacy profession, and the comments and opinions shared today are those of our hosts and our guests, and are not official statements of the MPA, Mercy, Mitchell Pharmacy, KPHE, nor VMC. Today, we welcome Dr. Tyler Woods, who is a consultant, an expert in independent pharmacy practice, and currently the Kansas Pharmacy Association treasurer. Welcome, Tyler.
Thank you for having me.
It's good to have you on. We've been talking for several months as to how we can get you onto our podcast and learn from you and share with our listeners the kind of things that you're doing in your practice right now.
Yeah, so like I said, thank you for having me. First time podcast, so this is exciting.
This is your first podcast?
Yeah, bucket list item here.
You're a mover and shaker. I thought you would have already had your own podcast by now.
Yeah,
so, well, you're starting on a pretty simple podcast, but we're glad to have you. So.
That's great. So yeah, I'll just kind of dig in a little bit about myself. So, I started my pharmacy career, I think like most of us, bright-eyed, ready for clinical dreams and changing the world. Nobody mentioned we would be part-time IT support or inventory managers or, almost unofficial therapists. But, along the way, I've owned pharmacies, launched a consulting firm, worked with payers to help independents get paid for this, care that they're already providing. My day-to-day really just involves helping pharmacy owners find clarity in the chaos, margins in the mess, if you will, and improve margins, clinical performance, and payer strategies. I'm a pharmacist turned pharmacy owner turned consultant. Just a fancy way of saying I've made all the mistakes, so hopefully you don't have to.
Well, I think that really sums it up right there. And when you said margins in the mess, I'm like, oh my gosh, that is so. There's so many pharmacies that are just trying to make sense of current reimbursements or, how they're going to move forward with the Inflation Reduction Act and all these other things. I know, Tyler, you're involved in a lot of things, and I know you kind of started talking just briefly about it, and I didn't mean to interrupt you there, but it's amazing how I've watched you over the last few years be involved with CPSN Missouri and your consulting and all the other things. Tell us a little bit about how that's been going, how you've kind of led up to that, and where you kind of, where you want to take it. So.
Yeah. So let me give you a quick story, because I think it'll set the stage for that answer a little bit. Recently completed my MBA back in December of last year. An interesting timeline. We were in, Tim, you were there with us, but at the NCPA fly-in, and, finding this regulation and trying to get some things accomplished within PBM reform. And sure enough, we're holding up this vertically integrated chart that we've all seen, and we're in front of legislators and kind of giving them why this is bad talk. And then I get home, and the next chapter, the next series in the coursework was vertical integration. And I was so excited. Okay, here we go. I'm finally going to be able to get this and be able to understand how bad this is. Because from a pharmacy perspective, when we hear vertical integration, it is the devil. It is as bad as bad can get.
You're right.
And I'm reading through the course, and I'm going through, and that kind of epiphany point that says, damn, they are teaching this in every business school across the country. And here we are trying to essentially lobby against why this is bad. So I say all that to say, when it comes to 340B or PBM legislation, we are fighting a very, very difficult battle, and we're doing some really, really nice things. But I think the message has gotten a little bit misconstrued in the sense that it's not a pharmacy issue only. It's definitely a pharmacy issue, but not singularity.
Sure.
And so from that standpoint, it was really moved me into this space of, if we can switch the plan, we can fix the pharmacy. And so really dug into employer benefits. And so that is a very complex world, as you know, but the things I've learned through those essentially just interests and wanting to learn more and help business owners change their benefit structure has helped me within the CPSN efforts in Missouri and some of the other things I've been working on, because it kind of pulls together and clarifies some of the things that we know are struggle points that are unique to our industry. So being able to kind of help bridge that gap of what are we struggling with as pharmacies? What are employers struggling with as employers? And how do we bridge those two gaps? And that has been a very, very fulfilling last 2 years in and of itself, to kind of get to some wins in that direction.
Right. I can tell you, I've seen the passion that you've had in meetings that I've had with you about, and the knowledge that's coming out of your brain blows me away. I can tell you're very passionate about it. So I appreciate your efforts for sure. Daniel, I want to go back just a second. You didn't introduce our guest co-host today. Do you want to introduce her before we go much further?
Oh, yes, I apologize. I just made myself a note of that. This is Angela Robichaud, who's actually a PGY2 ambulatory care resident at Mercy. And so we're pleased to have her with us today. Say hello, Angela.
Hello.
So, Tyler, she may be shooting the hard questions at you, because that's what we do with our residents around here, is we give them all the hard work, the heavy lifting for us.
We'll see what I can come up with.
So if you want to be on a podcast someday, become a resident for Dr. Daniel Good, and he'll bring you on in just a minute's notice. You won't even be prepared. So
Facts.
All right, Daniel, you can go ahead and take over and ask another question for Mr. Tyler.
Well, Tyler, your work has been amazing, and just your self-discipline to go and try different things, to go out and be an independent owner, to out there and be a consultant, to take those risk points. Reminds me a lot of Brene Brown, that says you got to be willing to fail in order to make the next step. And now you've taken it to the next step, even at the state level within Kansas. I know that you're on the board of directors there and sharing some of your expertise with the rest of the state of Kansas. Tell us a little bit about that.
Yeah, so I've been in Kansas City. Most pharmacists are dual licensed, Missouri and Kansas. So coming out of school, that was a dual license opportunity point. And I serve as the treasurer, and I'll be honest, this is selfish because Topeka is an hour from Kansas City, and Jeff City is about 2.5 hours. So just from a convenience standpoint, that was an easier drive for me. But I tell you, it's been really good. It's working with the associations. Always been a supporter of the associations, but I think there's times where we still undervalue some of the things that the associations do for our profession, and being able to be there firsthand and kind of help set some of those strategic initiatives. That's been very, very rewarding.
That's cool. And, the fact that you have the chance to kind of dip your foot in both states is pretty unique. And so you can bring strengths from one state to the other, or even, hey, like you said earlier, let's not make those mistakes because this is what we did at this state, and let's not make that mistake here, and try to. So do you ever see associations maybe working closer together? Like, say, I know, for instance, Kansas and Missouri both have had trouble passing PBM bills. I mean, is there ways that we can help, leverage some of our discussions and those types of things? I don't mean to just take over the podcast with a PBM, but what are your thoughts about, leveraging strengths on strengths between two states?
I think there's indirect opportunities where we kind of learn from what the other states are doing, and maybe the success they've had or failures they've had to that point. Like you said, Tim, I see more collaborative intervention opportunities within something like the CPSN channels, where if we can get regional contracts where, it's maybe not just Missouri or not just Kansas, but multiple states, I think payers look at that as a home run as far as opportunity there. Legislatively, it's a little bit more difficult because of the nuances between the states. But I think to your point of, hey, what's Arkansas doing? What's Oklahoma doing? What's Iowa doing that Missouri or Kansas can lean on and learn from, and maybe at least bolster some of our reform efforts that way. So I think there's some opportunity there. And it's been going on.
Yeah, and we've talked with Arkansas, and of course we all want to be able to have some sort of connection with what Arkansas is doing, as far as like eliminating vertical integration, like what you talked about, and it even though that may be the gold standard in business practice, in the healthcare area, we've seen what it's done to drug pricing and pharmacy reimbursements and so forth. So it's definitely something that I feel like we could probably build, between Oklahoma, Arkansas, Kansas, Missouri, Iowa, Nebraska. I'm just throwing out ideas, and I know that's been talked about before. So I appreciate your insight on that. So
Yeah,
Angela, go ahead.
Just to say, yeah, to that point, on that vertical integration, I mean, it's the behaviors that are inside that black box that are really the bad or negative impacting issues. And I think we got to do a better job as a profession advocating for ourselves. And I'll say this in two ways. Number one, we should be talking to other employers constantly.
Absolutely.
About what they're signing, because they have real pain points too that are very aligned with ours.
Yeah.
And then secondly, the ask that I would have for our profession is to continue to define our value above and beyond filling prescriptions. Right? Filling a prescription has value in and of itself.
Right.
But that's not our only value. And so we've got to do a better job of, number one, creating, and then number two, advocating what our value is to our communities. And there's a lot there. We just have to be better at showing and proving it.
Yeah, I agree. And I think, we're the premium. We've had a previous guest on us talking about, we are the premium. And when you're premium, you expect to be able to be paid in a premium status. It's just like if you buy regular gas or if you buy premium gas, you're going to pay a little bit more for that type of thing, but you're going to get better action out of that premium than you will something else. Angela, I saw you writing something down. Do you have a question for Tyler?
I have a few, but the one that you said when you were talking about vertical integration, you used the term black box. And I guess I'm a little bit unfamiliar with what that is. Can you talk a little bit more about it?
Yeah, so we have about 20 minutes left. So the next 25 minutes will be on that black box. No, in simple terms, we have a significant lack of regulation and oversight as it pertains to benefit administration. And so whether it comes from Medicare, Medicaid, or commercial side, the ones driving the practice are also the ones that own pretty much every piece of the pie, if you will. And so from that standpoint, we have this misalignment when it comes to what I call a commodity, which is dispensing a prescription. It really is more on the commodity side versus the service. So it's, as a commodity, it's a race to the bottom. In any way that these companies can kind of take something out of the middle, right, and then kind of boost profits, that negatively impacts both ends of the spectrum, being the pharmacy and the employer side. So transparency is probably the most important first step, as we mostly all know in that side. Yeah. That we've got to understand and show where the money's going, because we know it's going to places it shouldn't.
Right.
And that's that black box that we just don't have visibility into to be able to put our finger on it and say, on a legislative effort or even an advocacy effort, that this is what's wrong. More of it is just what we know but can't necessarily prove because we can't see it on paper.
Right.
Okay.
Well, I think when I talk to people, there are certain legislators that feel like this is not for the government, or this is not for our senators and so forth to be able to have a regulation on. They feel like the FTC needs to do that. I think there's a combination of different things. I think it's important that we just continue to keep our foot on the gas and trying to push this issue and be able to understand what's going on. Well, I appreciate getting some echo there. I think we're having some technical issues. Sorry, Tyler. Daniel, you on? You want to go ahead and ask another question?
Okay, we're good now. Apologies, we're in the same room. The computer connections are going out, so technical issues.
All right.
I will happily ask another question. You were talking about commodity and how filling a prescription and delivering the medication is a commodity, and you were talking about increasing service and really giving, I forget the exact term you used. What would that look like in a community pharmacy, I guess is my question.
Yeah, so I love to use this analogy of when you get your vehicle worked on and you get your bill and it's parts and labor, right? So you have your parts, which is your commodity, and your labor, which is the actual service. And for the most part in the pharmacy profession, we really haven't leaned into that service component as a billable or payable opportunity. So to answer that question, a lot of this is going back to establishing and champion our value set for the healthcare involvement. And one of the things I would say is, we've always been kind of called ourselves the medication expert. I'd like to stop using that term and use
not just medication. Yeah.
the disease state experts, because everybody, at least at minimum since for the last 20 plus years, has graduated pharmacy school with the doctorate coming out with, we know how to assess a patient, do vitals, kind of do lab work and, point of care style. It's not behavioral modifications. It's not just what medication you're on. There's a lot more that goes into that. So it's more of a disease state management expert. Those touch points that we have, which has the value of the script, filling prescriptions, is significantly, number one, underutilized in our world, because that is something that most, if not all, the other healthcare providers do not have and just wish they could. And we are so good at those touch points, whether it's through med synchronization or care coordination, that's where we can exercise our value and kind of show how important we are to the healthcare team, that payers, so again, your Medicare, Medicaids, and commercial side, look at that and say, that is a bonus for us. That is something that we can lean into.
Absolutely.
Because if we can kind of help drive outcomes, positive outcomes, reducing cost, and getting patients to where they need to be, whether that's a physician visit, a lab order, a medication refill, things in that space, that's a home run for us as a profession. And that's where our payer opportunities will continue to come from.
I totally agree, Tyler. And I appreciate, your insight there. I think there's so much that we get commoditized on a daily basis. And I think we all need to be lockstep together in what you just said there. I think it's important that the profession continue to tout what we can do. And payers are seeing it. I mean, you and I have been on calls with various third-party payers that are saying, we see the value in what you guys are doing. We just got to figure out how to make it happen. And Tyler's a mover and a shaker, guys, and he's gonna be probably nationally known here before long, just by some of the things that he's working on. I know. So anyhow, well, so as I always like to try to have some advice for students and young practitioners coming out of school, and we may have already kind of covered some of this, but where do you see the profession going? I mean, you've already kind of touched on this, but I know where you would like to see it go, but share with us, what kind of advice you give to students. If a student came to you and said, I'm going to be a resident with you for a year, what kind of things would you try to tell them? What would you try to tell them to focus on, and how to kind of gear their career toward where they're wanting to go?
Yeah. So, as a preceptor, I do this quite often. I see the profession continuing to morph into a clinical care setting. There's a lot of reasons for that. I mean, just the top two. Number one, we're almost mandated to do so because of the lack of reimbursements and transparency in the prescription filling side of it. We're also looking at this from an idea that we are approaching some of these provider shortages that we've kind of been banging the drum on for a long time, and the need, especially in rural areas and these healthcare deserts are going to continue to come up as far as a real pain point for populations and legislation. So I do believe that we will continue getting better options as it pertains to patient care, almost up to the line of diagnosing. So, hey, provider gets a diagnosis, give it to us as the disease state management experts, and we'll take it from here type of scenario.
Right.
My goal as a Missouri pharmacist, and it's so lucky to be in Missouri. I think we have a great group of individuals. I may be biased, but I don't think so.
No, you're not biased. We're all great.
And so from across the state, we have national leaders, to your point, Tim, that really are making a difference across the nation. And having that provider status, having a champion at the Missouri Medicaid side, and being a non PBM-ish, we're doing our own benefits at the Missouri Medicaid side as far as the state. Those things are so impactful that my goal for Missouri is that a pharmacist can soon, next few years, open a pharmacy and not have to dispense a single prescription. And I get kickback from that sometimes because, but that's what a pharmacy is. And my answer to that is no, that's what your perception of a
start
pharmacy
thinking
is.
outside the box here.
Right. I'm not saying we won't dispense medication. I'm just saying we don't have to dispense medications, right? There's a difference there. It's a nuance, but I do feel like we're going to continue to get more and more opportunities as it pertains to patient-facing clinical care. And that is where I think a lot of pharmacists are interested in leaning into more. And once we stop being too busy, essentially doing the things that are putting us out of business, we kind of refocus some of that time, energy, and effort into some other revenue sources, then I think these wins just continue to stack, and we just continue to move the needle faster and faster.
That's encouraging information to hear, and it's great advice in my opinion. Yeah, I don't want it. I don't think pharmacy needs to be considered like a factory where we're just making widgets and we're sending them out the door as fast as we can send them out, and that's what pharmacy has been commoditized to be. And we've got to change that outlook and the way the future is going to move forward. So anyhow, go ahead.
And we should change that perception, right? Not just with the patients, but with the payers, with our pharmacists that are out there, with the schools. So we start training our new graduates to be in that new mindset. I think it's quite a paradigm we have to convert back. We've let ourselves get too far into this hole.
Absolutely. Well, believe it or not, we're approaching the end of our podcast. I know these things really fly by. We're going to probably have you on again sometime, Tyler. But so toward the end of each podcast, I always kind of throw this question out. Some people like it, some people don't. But tell us a little bit of something, it doesn't have to be pharmacy related, about Tyler Woods, Dr. Tyler Woods, that maybe not everybody would know. That might be a little bit interesting that, kind of you'd like to share with everybody, and keep it G-rated here. So
fair enough. Yeah. So we, let's see, a couple things about myself. I'm kind of a homebody. I love spending time with the family. My wife and I love to travel, kind of foodies in that side. I very much enjoy, for the last 4 years now, I've been coaching my son's flag football. And this spring, in fact, Monday, we start our tackle football program. So most nights and weekends, I'm spending time, explaining to 10-year-olds why running the wrong direction is a problem. But I really did find a passion on it. I think coaching keeps me humble. Reminds me that leadership is so much about encouragement and clear direction.
Yeah.
And it also, it's a great metaphor for pharmacy or any kind of profession, that teamwork, there's constant audibles, and a lot of improvising under pressure that goes into that. So, other than that, and then 5 years in, this is our 6th year coming up with Chiefs season tickets. So
hey, Chiefs fan,
fall will be busy.
That's awesome. So follow up quick question. You like to travel. Where do you like to travel to? And then you said you're a foodie. So tell me what your favorite food is. So
Yeah, I favorite food is pretty much what's in front of me. Not a
Seafood, you
picky,
see it, you eat it, right?
yeah, not a picky eater in any stretch, but I will say traveling has been able to, we love to take our kids and introduce them to different areas, different lifestyles, and that kind of thing. We were lucky enough last year, my wife and I, for our anniversary, do a Mediterranean cruise.
Oh,
Tim, I think
awesome.
you just did one, recently too, and that was fantastic. It was one of those bucket list type vacations, and it was probably as good as I could have hoped for.
Awesome.
Seeing a lot of great things.
Awesome. Well, that's great. That's great.
Look at you, Tyler, checking off the Mediterranean cruise, checking off podcasts. This has been a year for you.
It's been a great 12 months, Daniel.
And he's going to keep going.
Well, thank you for being here today. You're definitely a patient care advocate. You're an independent pharmacy advocate. The consulting work you do helps bring clarity to some of this chaos. And for that, we do thank you for being dedicated to that cause. And thank you, Angela, for joining us today as one of our guest hosts. It's always good to have fresh faces and fresh ideas with us. And to our new podcast listeners, thank you for joining us today for this Pharmacy Frontier podcast. And please share this episode with your friends and seek out the previous Pharmacy Frontier podcast on your favorite podcasting channel. And until next time, remember, it's a good day to be in pharmacy.